Hi, my name is Alberto Fernandez from Ibiza, Spain. Would like to congratulate Dental XP because of its great work, sharing great quality of dental work, and also Dr. Maurice Lama for his warmth and for his easiness and communicating everything that he does, and to whom I owe a lot. The topic today is osseous regeneration in the management of soft tissues, binomial that it's inseparable. I would like to let you know that this is the initial portion of a conference that's about 5 hours long. And what I'll do is that in many opportunities, I will be adding the parts that are missing so that the user has no risk of missing anything of the conference. I consider that all of the conferences should be organized, and this is what I'm going to try to do. The next are the contents that we are going to talk about. We're going to see an introduction, which is short. We're going to look at some concepts of theory, our philosophy on our daily basis. We're going to look at some clinic cases. We're going to do a summary, and we'll have the opportunity to resolve all of your doubts and commentaries. All of these points are going to be shown on a footer, and this footer is going to be followed by a timeline that is going to indicate how much time we have left and where we are. And the introduction, I believe that we need to do is part from a medical base that will structure our foundation and give us solidity to solve our cases on a very satisfactory manner, not only for the patients, but for us. Before we get started, I like to give tribute to my island. This is a very small island in Spain, and this is one of the views that it offers us from its west portion. You can show the elegance, and it's a place that you can come and think. It seems like everything works very well, and when we see cases like the ones from Dental XP or cases in conferences or symposiums, it seems like everything goes very well, but I can guarantee you that we all have failures and difficulties, and it is in sharing these difficulties that we really get to learn. And from here, I would like to encourage you to share everything that goes well or bad. I like to show this case because this patient is an exceptional patient. She's actually a nun from a convent. She came to my practice referred so that I could try to save the upper left first molar implant. Everything was done very well. The implants were placed great. The surgeon was wonderful. The restorative dentist was an excellent quality dentist. However, one of the implants had to be removed, and we had a huge defect that had to be regenerated. However, the patient didn't want to do anything, and she was left with only 2 implants. For me, this is very sad, and these type of things that make me think. However, there are situations that I know there are authentic calamities, and these are types of things that should alarm all of us. This is another patient that comes to my practice. I do apologize for the bad qualities of the pictures. It's a case that came to my practice about 10 years ago with communications between its oral antral and oral nasal communications. The surgeon and the dentist were exceptional. However, when I removed the implants, the huge defects that were left, and it took me 5 surgeries to be able to restore this patient. I truly can tell you that from the initial to the end, we were to the limit of the tolerance of the patient. We could not do anything else. And this is another situation. This is actually my situation. The ones that I showed you before are not mine, but this is a patient that had been already treated. Comes to my patient, and like in the left image, with a situation that it's that requires a lot of treatment. At the right, you can see how bad I left this treatment after 100 visits to my practice. It took me 100 visits to resolve this case, and this is definitely very distant to an optimal case. It has many defects, many problems, but not even me or the patients able to continue to do anything else. I like to share it with you so that you can see and we learn and share our embarrassments. If I can only show you the two anterior central incisors, you may say that this case is not that bad, but in a complete case is not that great. In reference to the concepts of theory, we all have to continue to get ideas from here, there, and everywhere, and we keep them in our head. And from here, we actually make the foundation so that we can treat our patients on a daily basis. Among the theoretical concepts that we're going to review, there are a series of classifications that are going to help us to name the different types of defects and perform statistical analysis of them. We'll see the behavior of the autologous bone and the biomaterials and the concept that rises from the combined use of both. What we are going to point out is where we use autogenous bone and where when use different biomaterials. Speaking of the classification of the bone defects, there are many classifications. I personally like Homley Wang's, where he divides the defects considering not only hard and soft tissues in vertical, horizontal, and combined defects. The horizontal defects is where there's lack of tissue in the horizontal dimension, the vertical defects, lack of tissue in the vertical, and combined defects on a combination of both. I consider that even though the classification of Hamlai Wang is of great value, there are areas that are not described. So then what I've done is I'm going to share with you a classification that I developed, and I consider it very useful. This is based on Homley Wang's, that it's based in Cyber's classification. Basically, the horizontal defects, as you can see in the left image, is a lack of tissue on the horizontal dimension. This can be on the buccal or the lingual. On the right side, you can see how we can systematically resolve the situation with an onlay graft. It can also happen that this defect, horizontal defect, is not just due to the lack of buccal or lingual tissue, but also a combination of both. This is what we call the double horizontal defect. And like you can see on the right image, we solve it with a double onlay graft. In regards to the classification of vertical defects, to make it easy to understand and to take it to a clinical application directly, we divide them from defects that are either very apical and very coronal, understanding that the lack of bone is in the apical or coronal aspect of the ridge. And this can occur in the anterior or the posterior zones. In the left image, you can see a defect on the maxilla with the vertical apical defect that can be solved with sinus lift technique. On the right hand side, you can see an anterior vertical defect that it's in the coronal region, and this requires the use of osteogenic distractors or onlay grafts. The same as with horizontal defects, we can have what I called double vertical defects. That can happen both in the anterior or posterior region. To the left, you can see we will have to perform a sinus lift, but we also may need to do an onlay graft. To the right, we have a patient with a vertical defect in the anterior region, not only because of the vertical ridge component, but the nasal floor. So we will have to elevate the floor of the nose and perform an onlay graft on the coronal aspect. In regards to the combination defects, we will have lateral vertical defects, they can occur in the maxilla, in the anterior posterior region, same as in the mandible in the anterior and posterior regions. Up to here, the classification is very similar to the Honglei Wang, but I consider that there's some situations that are different. I may consider that he does not say, or not other authors mention, it is because of this, and with all my respect to Honglei Wang for his exceptional classification, I don't want to misinterpret. I consider that we have to include, as I call them, the through and through defects, and can be apicocoronal or buccolingual. Apicocoronal as the ones in the images. There are two entities that require name per se. The communication, oral antral communications, the defects in the anterior region, and the oral antral communication, the posterior, both are vertical coronal through and through defects. They're also buccolingual through and through defects. They are common. These are common in the treatment of odontomas or fissured patients, or for extraction of canines, and they require a very special treatment. Up to here, we have seen qualitative classification. We have been able to name horizontal, vertical, combined defects, or through and through defects. If they are missing one that it's quantitative, where I follow the one from Lei Wang. They're small when they're 1 to 3 millimeters. They're moderate when they're 3 to 6 millimeters, or they're severe when they're greater than 6 millimeters. I consider that what we have seen now, we can actually mention any type of defect as we do on our daily practice. In regards to the regeneration techniques, I consider that they have been actually managed in an individual manner. There are different success rates for this or that technique, but an important aspect at the moment is in which techniques are performed is what I consider has not been taken into account. So because things have changed in time, I have to organize and the moment in which the techniques of GBRs are performed. So I consider that there are 5 different steps in regeneration. The initial step, where we want to, is try to avoid or reduce the bone loss. In this step, everyone in the office plays a role, from the endodontist, the hygienist, everybody, or all the treatment is very conservative. Why? Because what we're trying to do is to reduce the need to extract teeth. And if we have to extract teeth, we have to reduce the amount of bone loss. In the second type of regeneration, which is the secondary, we are in a situation where the bone loss is already there. And what we have to do is, before we place the implants, try to modify it or resolve it. The tertiary type is one where we have a defect, but it's not as severe. It doesn't avoid the implant placement, so we can perform regeneration simultaneously with the implant placement. In the fourth step, which is the quaternary type, it's a more common situation. The implants have been placed, they have been loaded, and for some reason they have started to lose bone. The threads of the implants may be exposed, and they have been contaminated with biofilm. This fourth step, what tries to do is to reossify the exposed and contaminated surface of the implants. In regards to the fifth type of GBR, is in this situation, everything has gone wrong. The patient has had implants, but we have to remove them. And from here, we're going to have to start from scratch. We're going to have to start from bone regeneration and restore the case. I hope that you can understand. I don't want to be telling you a whole in detail and get you all bored with this. In GBR, if we look at the initial step, what we try to do, as I said, is to avoid bone loss. What we do is we start from the moment that we extract the tooth. It has to be very conservative, and we have to treat the socket in a very nice way to reduce the amount of bone loss. Techniques like the biocol or many other techniques allow us to reduce bone loss. However, all of this occurs, but what we're trying to do is to leave the roots. We submerge the roots, and I could say that the loss of tissue is near to zero. The secondary type, as I mentioned, the bone is already there, it's present. What we have to do is to treat it before we place the fixtures. Literature indicates that there's a great advantage of doing this because it allows us to place the implants correctly in a healthy environment and with a high success rate. The third type, like I said before, they're the defects that they exist. They allow us to continue, place the implants, and perform GBR simultaneously. Literature presents a very high success rate in these cases, but we have to cautiously treat these cases because if something goes wrong, there's a lot of loss, not only economically, but also the confidence of our patient. So the third type, you need to be very careful and when you do them. In regards to the fourth and the fifth defects, these actually are becoming more and more frequently. I really consider the type 4 are the ones that have the lowest success rate. There are many doubts on how to decontaminate the surface of an implant. We know that we can do this because of the literature. We can do reossification that can be achieved on a surface that has been previously contaminated with biofilm, but the success rate and the percentage of reossification is lower. In reference to implants that is losing bone, there are many papers that shows us different algorithms that allow us to know how to treat many different cases. This is not the topic of this conference, so I would not like to share with you any of these papers. As I mentioned before, there is evidence of reossification could be accomplished. In reference to the type 5s, it's the one that gives me the highest satisfaction in reversing the management of failed structures. These have to be redone and sometimes regenerating the ground. And in reference to these failed structures, Dr. Mache has done several studies on the behavior of areas of failure that have done it either failed once or twice, observing that the rate of success is lower. What indicates that there must be a local problem. Something has this area that makes it worse. My personal opinion, which I mentioned with maximum reserve, is that it has to do with the vascularization of the area. However, in all this, we have to trail very carefully because everything doesn't need to be what it seems like it. And sometimes we get disappointments. What I refer to here is the techniques like the biocol, where if we choose an unsuitable moment or the patient to do this technique, we may end up failing with this technique. What I refer here in particular is like the text you just saw. When an area is treated, it has a history of infection, trauma, or endodontic therapy or previous surgeries. The surgeon should not panic when he returns to the site and the tissue that he had placed before had not ossified. This is due most likely to an alteration in vascularization, and we need to trail very carefully because we are actually putting into play our personal confidence in obviously the patients. So my advice is to review the history of the cases and do not guarantee success to the patients because sometimes we may not be able to obtain it. However, I don't want anyone to consider that GBR is not successful. I consider nevertheless the total opposite. Today's osseous regeneration is a reality that we cannot abandon. At the end of the 90s, authors like Buser, Fugasoto, Uvavina, Nevins have indicated that the percentage of success rate of implants placed in regenerated bone is similar to the native bone. Therefore, not only you can regenerate bone, but its behavior is similar to native bone. But what is the behavior of this bone? There are a series of factors, the situations that have gotten stuck and may have not major accuracy. So I would like to deny some of them and share what has been my experience. In reference to the autogenous bone, their behavior that has been said in many occasions, they're still being said that the origin, the embryological origin modifies the behavior of it. So it seems like the bone that was cardiogenic before it ossifies has a rate of resorption much higher than the one that ossifies from its collagenic portion. This theory has been mentioned in many cases. However, we know today that this is not true. The characteristics that govern the bone behavior have nothing to do with its origin. So it has to do with the architecture of the bone. So as you can see on the right, an image of bone with spongy origin, as you can see, has a cortical portion that's very thick, but with a spongy component that it's much more looser. Both have the same origin, but their behavior is different. It is evident that the cortical bone will be very resistant and very difficult to vascularize. The spongy bone will be very easy to vascularize, but not very resistant. I would like to share a case with a patient that comes to my practice with a severe decrease in the right maxillary area and moderate on the maxillary left. The maxillary left can be treated by placing short implants, and the right side, the defect is very severe. It is a through and through defect. It's combined and through. We have vertical and horizontal loss, and I also have a synequia of the alveolar mucosa and the sinus mucosa. This case, as you can see in the image, is going to be managed with the bone that I continue to believe is the gold standard. And in this particular situation like this one, the patient we actually treat and surgery with under general anesthesia with a hip graft to try to resolve this situation. You can appreciate in the coronal slice how we have on both sides the image of the left that corresponds to the image of the right. You can see we have enough bone with a very clean sinus. However, the same liver, you can see that on the right with the image of the left, you can see how we are in the anterior area and it's almost no sinus and the alveolar process has been lost. The situation we can manage with zygomatic implants or any other type of access. However, if we go farther distal, you can observe how the alveolar process has been totally lost. And what we have is a synequia of the alveolar mucosa and the mucosa of the sinus. And the bone goes to a much higher position. Truly, we have a defect that it's way above the horizontal position. What we do is to go to the hip, and you can observe on the left image how after we elevate the flap, we have a synequal of the portion. This is what I'm going to show you with this arrow. You can see how you can see a defect, that it's a synequia. We eliminate it with a blade, and then we can observe how we do the cortical and cancellous graft of the hip. In the image in the middle, sorry, then you can see the defect, and now we manage it with the use of a combined graft. What we try to do is, again, gain 18 millimeters of vertical height with the gain of horizontal component. What we do is basically restore all of the lost alveolar process. This way, what we see on the right are 20 millimeter screws that join the little pieces of the remnant bone that we had. What you can observe is in this sequence of images is how the initial situation, we place the cortical cancellous graft. And what I was showing you with the moving point was the cortical portion. 16 weeks later, you can see in the middle image how the cortical portion is just remodeling with minimum resorption of the cortical portion. However, the spongy portion has been almost all lost. This does not impede us from placing our implants, as you can see on the fourth image, and in the simultaneous GBR techniques to regenerate the tissues. In this case, with biomaterials and PRGF and PRF. In the histological study, we see that the biopsy that we took indicates that we have vital bone. All of the lagunas have pigmented areas that indicate live osteocytes. You can observe how a situation like the one that we just saw allow us to regenerate the defect in its totality. And true, there's a concave area that we're managing with an implant placement at tissue level where a machine neck allows the gap to be distant and not let it become a problem. And we can treat it with a CT graft so it doesn't become a problem. In reference to what I am talking about there, it is a situation that I caught my attention some years ago, and I researched it, and it was what I knew that the embryologic origin did not seem to affect the bone behavior. However, up to what I know, no one had combined bones from different origins. So what we did in this study was combined bone from the tibia with bone from the ramus, with embryologic origins that are totally different. And however, the behavior we had was exactly the same. You can observe one of the cases in the left image where we obtain tibia bone. We obtain a huge amount of particular bone in a very simple way and almost in a minimally invasive manner. In an image that follows, we can see a monocortical graft of the ascending ramus. We continue with an elevation of the sinus and a simultaneous regeneration of the vertical defects with the alveolar portion. The combination of both bones and techniques allow us to obtain an adequate result. And as you can see, the placement of implants in adequate positions in soft tissues, management with pelagic closing, an image of the right because we took a biopsy that will indicate that we are upon bone that once again is vital, and we can there's no differentiation of any of the behavior of the bones that come from the tibia or the ascending ramus. In reference to the bone behavior, there is a concept that I believe it's very important. It is the concept of frame of bone. It's a concept that Dr. Fuori taught me, and this concept is truly, I owe him all my respect because he made me understand things right, and I use this daily. This concept of frame of bone, what says is that all the bone defects that are areas that are kept in the interior of this bone frame and it's not more than a defect that it's surrounded by healthy bone cells that can contribute healthy cells and vascularization. These defects appear within the bone frame and is what I determine as green areas, areas that are determined in this diagram with light poles and zone senates that give the vascularization and cellular support that are important for the regeneration. However, there are zones that are left outside of the bone frame where they escape this vital support, so the regeneration in these areas is not as satisfactory. There is a limit area that actually joins the bone spikes that determine exactly the bone frame. Like this, as I said before, we have a green area that is contained in the interior of the bone frame and a red zone that is farther from the bone frame. In the study of Corey, it does a very good analysis where in horizontal defects, he measures the amount of bone available at the beginning, and then he measures in the immediate postoperative. He gains up to 7 millimeters. So he can place implants and separates his cases on the following. Cases that are inside of the frame of bone and no implants are placed. This is observed is up to 18 months, and there exists a minimal bone loss. However, what he observes, once bone is regenerated in a horizontal direction, it is within the bone frame of the bone volume is maintained. So the placement of implants within the bone frame and the load of the implants maintain the volume of bone. However, if we go beyond the bone frame, and I manage with autologists, if we do not place the implants, there is a severe bone loss mass. However, with this situation, with the placement of implants, the tissues are maintained. There is some decrease of volume, but not as we had it if implants had not been placed. This follows the loss of warts, where the implants placed or the loaded implants placed on the subjacent bone, the bone is maintained. We will see a case that I did about 7 or 8 years ago. It's a patient after a car accident, needs regeneration of the anterior maxilla. So we go to the cranium, we place a series of implants, type online, and actually grafts type online, and we fill the gaps with same type of bone. At the beginning is of desmal origin, but the rate of resorption should be really low. However, observe on the right image how we have an area of 2 onlay of the left. They're supported over the bone frame. They're close to the canine area, and the most medial graft is supported on the nasal spine, and on the apical portion. However, the 2 of the right are totally out of the bone frame. We will see the behavior of what we see after closure after 6 months. It is the area on the left, which is the right of the patient. The zone that was inside the bone frame is kept in full. There is a slight remodeling, however, but it is kept satisfactory. However, the right image that is the left of the patient, you can see how there's just a little bone in the areas of the screws that are fixating the graft. What forces us to do new techniques of bone grafts to repair the areas of fixation. See in the right image how we had to do a new graft. We had followed this and have arrived at results very similar to Dr. We have followed our cases and have seen that in those zones that at 16 weeks, using 16 weeks our cut point, the zones that were inside of the bone frame had great stability of the tissues and shows in yellow. In white, you can see the areas that are out of the bone frame with a rate of resorption very high. Like the case we just saw, however, when we placed implants in areas, the bone frame, the behavior was much better. This made me thought of several doubts that we had to accept. With the management of autologous bone, we had to lose volume. To me, there is a fundamental aspect, that is the concept of time. So if we go beyond the bone frame, we should place the implants before the 16th. In reference to tolerate loose bone, this blue line should go farther. We cannot tolerate this. We cannot let this blue line continue to do down, and that's why we should continue to use biomaterials in a systematic way. It's because of this that the study of Lucas Tarola, who is student of Quarry, is doing the same as I am doing since years ago. We use xenografts of bovine origin after the bone graft to maintain the volume of the grafts. In this paper that I recommend, you can see what he does after bone graft implant placement. He uses biomaterial, in particular BioOss. In regards to papers that are actually part of the universal dental literature, this one by Carlo Tinti is one that I like very much. It's about the limits of GBR. He speaks about the peaks of bone as the limit of GBR, the defects. Speaking in this article, Dr. Tinti says that the risk of his technique is, it has to have a learning curve, and the achievement of initial stability is difficult, and the healing time for integration of these grafts is long. He also still recommends hip grafts for dentalist patients. Carlo Tinti indicates his long-term follow-up. In reference to the hard tissue management in horizontal defects, Lei Wang has an algorithm that I'm not going to say in detail. It is a simple algorithm if we compare it with the one he published in the soft tissue management. What I would like to point out is that he demonstrates that the behavior of bone is pretty simple. Speaking about GBR techniques, I would like to mention Dr. Carl Misch, as you know, an exceptional professional who has developed an enormous number of protocols and classifications that are very actual. In his book, Dr. Misch indicates that in case of inadequate bone volume, the surgeon should decide the technique in a certain way, initially thinking about grafting the area. If it is not possible to graft the area, think about having a pontic. This slide is to consider the greater importance of the regenerative techniques. The initial election when there is no bone is to place bone. In regards to the behavior of the grafts, the wide monocortical grafts are very rigid and difficult to vascularize, but they preserve volume very well. The particular grafts vascularize very fast, but they disperse easily, so they require contention methods as collagen or Gore-Tex barriers or thin cortical films as in GBR. In our protocol, in our practice, we include many materials, and what we do is an immersion of the F1 fraction of the PRGF of the bone graft. Either it was even that we had harvested either intraoral or extraorally. I want to present the case of a young patient who after a motorcycle accident comes to the office with an anterior defect. In this case, we did an inlay type graft, a segmentary osteotomy to extend the anterior portion of the maxilla. You can see how on vertical incision of the mucosa alveolar, we cannot see the coronal area of the alveolar process, and we extend all the way the vertical component. 16 weeks later, we obtain perfect ossification, vascular tissues, and however, in the coronal aspect, we have a level off of the spikes of bone. We do not gain too much in the coronal aspect, but we have rectified, which is something that we could have hoped for. However, when we moved this segment, this was not the form it had, but was able to vascularize because of the bone spikes. In the biopsy, you can see there is laminar bone, it's healthy and vital. In the same patient, we have an onlay to gain horizontal volume. On the left, you can see the day of surgery. Then 6 weeks post-op, the bone volume is almost the same. It's vascularization, and there is remodeling. You have to be very careful in dealing with these type of grafts because if we do not eliminate the areas that are not vascularized, these can be exposed. There's just remodeling. In this image, you can see the left excellent volume, and in the right, we did the restoration using the roots to do a good restoration that it's satisfactory. In this case, I sent this to the prosthodontist, and he would be the one who finishes the case. Let's see this patient, a little older one, not as athletic, comes with vertical defects as we manage and with an onlay graft and an inlay to gain horizontal volume. We close. We have been able to level the defect. See again the coronal aspect of the bone. It is completely leveled. These cases I like to share with you because these cases show me how these theoretical concepts are actually continuing the flow, and we see that these concepts do follow what we see daily. The bone frame concept truly is of great use, and if we don't take it into account, we may not be able to regenerate the bone. In the same patient we just saw, we did on the left side, the maxilla, we removed some implants and we did a vertical regeneration on the coronal aspect. We used very thin cortical from the ramus. We used very thin cortical from the ramus. You can see how we supported on the bone spikes, and we filled the spaces with particular bone from the tibia. We also elevated the sinus, as you can see on the right, and the sinus elevation again on the right. You can see 16 weeks later, we have healthy bone, vital, a cortical that it's a little bit ischemic. We are able to level our implants, and from here we can restore this patient in a very good way. Histologically, with coloring of niacin, you can see the collagen and the areas of calcification are all the same. All of these areas show that we have living cells. There is a technique of lots of interest, and I can name the Salama brothers um, with all respect and lots of admiration. What they indicate is that to move the bone spikes, they can utilize orthodontic extrusion techniques to pull the tooth and make the bone spikes grow more coronally. Here you can see how we are utilizing the concept of much interest. We have this tooth that is distal, has healthy bone, but in the mesial area, no bone. If we needed to regenerate this area, it would be really difficult. So what we did was we extract this tooth, we place implants utilizing the bone spikes left and then from here we will regenerate with autogenous bone. In biomaterial on the left, we did an onlay graft, and then we used the bone spike, so increasing vertical bone. We can increase the length of the bone spikes by orthodontic extrusion, or we can extract the tooth, and then we can use that bone spike most distal. As an alternative to what we are seeing, the literature shows the management of Noe that can regenerate the bone upon an exposed root, and from here do techniques of GBR. My experience in reference to this is not consistent. Sometimes it's good, other times it's not so great. So we have we have to sometimes extract the teeth, but nevertheless, it's an alternative for regeneration. So this is a formula that I have developed in reference to the behavior of the bone, where we have a series of factors that are the height of the bone spikes, the angle that they form, and the distance between them. So the greater the distance, the lower the success rate, and the higher the bone spikes, the greater the percentage of success. In this study, again from Wong and Galindo Moreno, they indicate that the defects, the actual length of the defects in the maxillary sinus behave differently independently of the material we use. So the greater the distance to the palatal aspect, there is less rate of ossification, as you can see here. So the component of distance is very important. It needs to be taken into account. So that's why in wide sinuses we still use autogenous bone. In reference to the behavior of biomaterials, it is interesting to see the different types of what we'll do. There are some biomaterials that are resorbed fully and very quickly with a very fast change. This type is the beta CTP, and we use it in the inside of the bone frame because it is quickly substituted by new bone. In this paper by Danny Boozer in 1998, he studies pigs, and you can see that in few weeks, the behavior of the beta TCP is excellent, surpassing in some cases the autogenous bone. It is because of this article that we use biomaterials inside the bone frame, so that where we need to reossify the bone, and we use beta TCP. However, if we use the beta TCP out of the bone frame, what we will see is remodeling and resorption of it and no gain of bone volume. What we want is that if what we want is to maintain that biomaterial, we need to keep something that stays forever, like diamonds. this histology view of xenograft, what we see is inside of the bone frame on the left and out of the bone frame on the right is after 5 years of placement. The volume is almost kept. Inside, it is colonized by osteocomponent cells, osteogenic cells. They will also be resorbed and new bone will be deposited. And the area outside of the bone frame on the right side is going to be encapsulated, but the volume is kept. Here we see the same with Mason. In this paper of Araujo, he analyzes, it's a study with dog craniums. He does grafts of the same size and volume of autogenous or biomaterials, either xenografts like BioOss. At 6 months, where autogenous bone was used, where a lot of bone loss was shown, and BioOss, the volume was almost all kept. However, we're only looking at volume. If we look at new bone, the autogenous still shows vital bone around the fixation screws. But in the BioOss area, there are very few areas that were subjacent to the receptor area. However, the volume is kept. What this means is that the autogenous bone out of the bone frame will resolve, will generate new bone, and the biomaterial will hold the volume, but new bone is only ossified subjacent to the bone. This is the left image. You can see the histology and the biomaterial out of the bone frame and completely encapsulated by connective tissue, and the one that it's in contact to the receptor site has new bone. This is something that is not bad. It is something we should know, and if we extend beyond the bone frame and place a xenograft, we will know that it will be encapsulated, but will keep its volume at expense of abundant connective tissue. It's because we use it in this concept. There is another type of biomaterial with slow resorption. There are synthetics. They combine beta-CTP and hydroxyapatite synthetic. There's a study from Danny Boozer that is very analogous to the one that he did at the end of the 90s. This one was on the early 90s. He uses pigs, and with ramus defects, he grafts them with different type of biomaterials, xenografts, or synthetics. He sees that the behavior of the beta TCP, like the one he saw at the end of the 90s, very similar to the autogenous, and in some areas even better. However, when we see a longer time the synthetic bones, the synthetic bones actually behave a little better than the xenograft and the autogenous bone. I personally cannot make any conclusions. I think this is useful, but again, I will not make conclusions about this. What I just conclude from this article is that this synthetic material is an alternative for patients that cannot allow us to use xenografts. So in my daily practice, we utilize autogenous bone to regenerate outside of the bone, frame and outside of the frame with xenografts. If we cannot use the xenograft, then we use a synthetic bone. Inside of the bone frame, we use beta CTP. There is a concept that unites the concepts of bone and biomaterials, and the literature defines this as a sandwich technique. The xenograft, what it does is to reduce the rate of resorption of the autogenous bone. It's like the warrior at the beginning. So our protocol is, I'm going to share it with you. In defects of bone frame, we place implants, and we have a small defect contained in the bone frame. We place xenograft with a collagen membrane, and what we can expect is that the zones inside of the bone frame will ossify. What we call the green zone will ossify. The red zone will have biomaterial encapsulated in the connective tissue. However, the volume will be fantastic. If we are out of the bone frame, what we'll do is graft with autogenous bone and outside a biomaterial in a collagen membrane. This article, again, from Luca Stavola, I had showed it before. What he does is pretty much what we do every day. After he does autogenous regeneration, he places the implants at the same time. Then he grafts with xenografts, mainly BioOss. This is a younger patient with vertical defects. We have to place the monocortical graft wide. In the middle image, the graft is actually longer than the bone spikes. So after we fixate it, we will remodel it to make it sure that it's kept within the bone frame. We look to obtain the bone frame completely defined. Then we place the BioOss material and the collagen membrane. Completely fixed 6 weeks later, after we have ossification, there is an area, place of the onlay close to the tooth. There is a place that it's like not well irrigated, so we need to eliminate it because then we can get exposure and contamination. The case goes back to the referring dentist for restoration. In the same patient, I want you to see we did an onlay with support in the bone spikes on mesial and distal, and we want to do GBR with autogenous or with beta CTP or xenografts. This is the first part of the conference. I hope you find it useful. From here, we will continue to be able to do more presentations and offer from here to resolve any doubts that you may have. I would like to congratulate Dental XP for the great job they do. Thank you.